Thank you to all of you for joining us today. As Tony mentioned, I'm Daria Ferro, and on behalf of Dr. Winston and myself, I just want to thank you for joining us to really begin a conversation about how we can move towards an innovation ecosystem. Are you guys seeing this? So in full disclosure, here are our financial disclaimers. And I just want to start off by saying that, we really have a lot of people to thank and to acknowledge. Flaura and I are the people who are speaking here today, but none of what we're discussing would be possible without the tremendous support, ideas, and hard work of a lot of different people, both in our internal and external networks that we happen to be privileged to be a part of. And this is just a partial list of those individuals, and it really does take a village to do this kind of work. And so just by a show of hands, getting a sense of who from our village is here, I want to get an idea of who is here in the audience. So can I just get a quick show of hands if you consider your primary work to be like in the research space? You're primarily a researcher? Great. Clinician, like clinical care delivery? Awesome. And then what about hospital operation quality and safety? Super. And then anyone from administrative roles, information services? Great. And then anyone who just works at Penn and primarily not here at CHOP? Awesome, great. Thanks so much for coming across the street on this cold day. So thanks for helping me to understand who's here in our audience. And I think this really goes without saying that, the future of pediatric really requires innovation. And if we look at the growth of health informatics discoveries and research over the past 30 years or so, we've really seen exponential growth in the literature in terms of this. And so on the left, we have a graph that's showing the growth of publications, from 1990 to 2010 with that hockey stick type curve. And on the right, you can see that there's, over 12, looking at Google Scholar, over 12,000 publications since just 2018 when you search for health informatics. And then along these lines, we've also seen dramatic growth in health IT infrastructure as well as companies. And so these are just some of the companies and technologies that should be enabling the process of translating all of these discoveries into the clinical care. But also what we see is that commonly these companies are failing, and even maybe most fail. And there's maybe multiple reasons for that. Failure is to be expected in some ways. Healthcare is a very complicated system. It's highly regulated, and where is appropriate, it's high risk. We want to avoid doing any damage to patients. And there are many stakeholders that need to find stakeholder alignment. And there are many implementation pain points with integration of systems. Mismatched incentives, so academicians are promoted based on number of publications, not necessarily on the impact of the work. And health IT is primarily seen as a service as opposed to a development. And there are lots of silos because people are not often incentivized to collaborate, and as such, many islands form. And the reason why all of this is important is because with all of these discoveries and some expected failure, all of this work is not leading to the potential impact that we would really like to be seeing. And as a result, people are frustrated, and that is patients and families, that's doctors. Clinicians aren't able to deliver the higher quality care more efficiently and easier as initially promised. And patients or families are frustrated because it's changing the way that they interact with their healthcare teams, and not necessarily always in a better way. But meanwhile, there are real problems that still need to be solved. We've made a lot of progress over time with our advances in healthcare, but for example, children with asthma, still 1 in 2 have an asthma exacerbation in a year. Teen driving is still the #1 cause of death in teenagers, with 1 in 3 adolescent deaths attributable to a fatal car crash. And all of this sounds like a little bit worrisome, but I think this is one of the things that makes me feel very, very lucky to be here with people like you and to be here at CHAP, because CHAP has been at the forefront of solving these problems for a very long time. We have the great fortune of standing on the shoulders of giants and the experience of an institution that really knows how to execute and deliver. And the talent we have here really can develop the next breakthroughs in innovation. But all that said, that doesn't mean we can't do it better. And that's what we're really here talking about today, building on CHOP's great strengths to push pediatrics healthcare forward. And really, this is the beginning of a conversation. We're really excited to hear your ideas about how we can all work together to move forward. So with that, today we're going to be talking a little bit about building on CHOP's innovation strengths. We're going to be focusing on 3 objectives. I've already used the word innovation a couple of times, but really starting to define more clearly like what I mean when I say innovation so that we can have a shared mental model of what that means. And then also this concept of the valley of death. What does that actually mean? Then we're going to talk a little bit about how we think we might be able to start moving CHOP into an innovation ecosystem, and also a little bit more about what we mean by the term ecosystem. And then we'd really like to have some time to hear from you and to think about ways that we can all work better and create this ecosystem, because it really is going to be a group effort. So starting with innovation and the valley of death. There's lots of I's that we talk about, so invention, innovation, ideation, iterate. So we're talking here today specifically, improvement is another big one. So we're specifically here talking about innovation. And I just want everyone to take 5 seconds and to think about what that word means to you. Like, what's your definition of innovation? And I think this is a really important exercise because even amongst our innovation team, we are often using the word and I think meaning different things. So we'll just take 5 seconds, think to yourself what innovation means. Okay, got it? It's in your head? All right, good. So I want you to just hold it there because we're going to share with you what our definition of innovation is. And I want you to compare it. You could tell us how we're wrong and you're right. So innovation literally means in a new way. It's the idea of taking new concepts and knowledge and being able to convert that into new products, services, or processes, which ultimately deliver new value to the end user. This is really important. Innovation might not involve new research or new technology at all, because there are actually many types of innovation. I think all of us immediately think about a product, what's the new gadget, what's the new app I can build, that's the thing that's innovative. But really, there are other types of innovation. So process innovation, thinking about how you can totally rethink a process to continue to deliver new value. So I think of this in my real world is like my banking. You used to have to go to the bank to get money, like to cash a check, to do all of those things. I'm going out to dinner with friends, we're going to split the bill, I need cash, okay, I have to go to the bank. I never have to go to the bank now. My paycheck is directly deposited. If I get a check in the mail, I take a picture with my phone. When I go out to dinner with my friends, if we need to split the bill, I say, what's the application that you use to send you money? So maybe that's Venmo. So it's a really rethinking of a process. And then ultimately, there's also the business model innovations. And this might be an example of thinking about some chemotherapies, right? Previously, if you needed to go to have any chemotherapy, you needed to be in the hospital. And being in the hospital is expensive. And some smart people said, well, do we need to have everyone come to the hospital to deliver chemotherapy? Maybe there are a certain group of patients where we can mitigate any risk and they can actually get their chemotherapy at home. And that actually is better for the patient because it's more comfortable and actually overall saves money in the healthcare system. So that's a business innovation. And ultimately, again, our goal is to hit this target and think about how these innovations can deliver value. But the fact is that along this process, we get it wrong a lot. Many times we don't hit the target, right? And then even when we're doing that, we have these epic failures and things just don't go as planned. But that is actually part of the innovation process, missing the target and learning from your failures. So what does it mean to really think about a true opportunity delivering on this new value, on this innovation? Well, we think you need to have like these three pieces. And we actually are pretty confident that no one person is actually going to have all the pieces. This is, really emphasizing where it does take collaboration and work amongst groups, and it's going to take everybody here to figure out how to really start to deliver value in innovation. And again, these opportunities are different types of opportunities. They might be new products, new processes, or business models. But I also told you that failure is really, really common in innovation as well. So what are some of the ways that we can commonly see people failing, and maybe start to think about planning for failure and predicting them and systematizing in a way to help people fail faster and learn better so that they can more quickly get to that value, which is the true aim. So one of the first ways that we see people fail is thinking about having a need and having a breakthrough or discovery. So you have these two pieces, but you don't have the ability to deliver. And so you have a product or service that you can't really deliver. So this is, some research program that has 20 sessions that deals with complex medical and mental health needs, and they have there's lots of direct observation and specialty involvement, and it works, but the ability to scale that is just not going to happen. So you have a need and a breakthrough, but not necessarily an ability to deliver. Another common way that we see people fail is thinking about having the ability to deliver and a discovery, but something that no one wants. And maybe this is like something like the Google Glass, right? Kind of a cool technology, we can do it, it's like available in the marketplace, but like no one really buys it because we don't really know what the need is at all. No one really wants it. And then another common way to fail is when we have this need and ability to deliver, and that really winds up with this unfocused product or service. So many people might feel this way about the electronic health record, right? We have the need to have access to our data, and we've clearly shown that we have the ability to deliver that. Most hospitals now having electronic health record, but ultimately it's unfocused. People are feeling like the EHR is optimized for no one and everyone, or no one and nothing rather, except maybe the billing. So what do all of these failures mean, right? We know that they're gonna happen, we kind of expect them, we wanna be able to learn from. What do they mean for your innovation? Do you continue and pivot with your idea? Like, how do you decide? And that's really the critical question. And it's the reason why so many discoveries never really make it to the clinic, because people give up or they're not willing to pivot on their original idea. And part of that is related to this concept of the valley of death, this decision-making space. And just to orient you to this graph a little bit on the, I actually didn't check. So on the x-axis, we can see that there are resources. On the y-axis, although it's not, y-axis, x-axis is time. And then on the left here, we can see that there are existing research resources, and then on the right, existing commercialization and operation resources. And the space that we're talking about is this decision space. And ultimately, when I'm talking about resources, I'm talking about time, people, space, expertise, lots of different types of resources. And it's in this decision-making space where you can also see it's really hard, and also it's the current place where we don't devote enough resources, right? That's where the least amount of resources and a very challenging time to figure out how to move forward. So I think this is the area where you can really improve, and the question is, how do we do it? And there's really an approach to this decision-making process that's really can be systematized. It involves de-risking your innovation by identifying falsifiable hypotheses, testing those hypotheses, accelerating when it's appropriate, and then de-risking again. So in short, it's trying to find out what's the fastest way that you're wrong. What's the fastest way that your innovation is going to fail? And then going from there. And this is not a linear process. It's very cyclical. And it's really important because it actually might sometimes send you back to the lab. You might not get to move forward. You might have to go back and do some more research. And some ideas might be great, but we might not be ready for them in the clinical setting. And this is particularly important in healthcare because there needs to be alignment with the regulatory and payment structures. So for example, I think we've seen this like with telemedicine. It's now approved by insurance, but prior to that, like there wasn't the uptake that we expected to see in telemedicine. So that really had nothing to do with the product innovation itself. And while we don't have all the answers, we're going to share with you 2 examples that we've discussed, or we've had some success with, and it came on the backs of lots of trials and falsifiable hypotheses. So the first is about pediatric asthma hospitalizations here at CHOP. So about 1 in 3 patients are hospitalized here each year, and some of these patients are seen multiple times in multiple settings, and they're actually distributed amongst all the patients in the ED that the providers are seeing. And one of the challenges for our ED providers is to know, well, who are these higher risk patients who have multiple visits for asthma so that we can kind of target them and make better clinical decisions for those patients. And it turns out that this is actually a really cognitively burdensome task for providers. The EHR is not helping to facilitate this. The data is there, but they have to search through it and piece together all of the information, hold it in their heads. And they're trying to do this in a very fast way because there are other sick patients and there are lots of calls that the providers are getting. So our EHR really didn't have a great solution for helping providers identify these patients in a fast way to create an accurate mental model to act on for dispoing patients. And it turns out that this wasn't a completely new problem, and researchers here have actually already come up with a solution for how to do this. So being able to bring all the data in the EHR together and present it in a summarized view that providers can act on quickly. And our falsifiable hypothesis for this was really, will this work for clinicians in the ED setting in the context for asthma? Would this data be readily available? Would physicians find it useful? And would it improve their efficiency and help them make decisions for patient care? So that's what we did. That in this decision space, we continued to iterate and adapt what had been done previously, and then we went to our users and said, tested to see if it actually saved them time and helped them improve care. And ultimately, this is what we came up with. This is the current working iteration of this application, which I am happy to say is being used in the emergency department and being managed by our information services operations team. But the truth is that this is I don't even know what number iteration of this this application, and because we didn't get it right at first, and we learned along the way. And even once we implemented this, we realized we hadn't viewed this in the natural environment in the ED setting. We started getting feedback from users to say, there's something wrong. And when we went and looked, we learned that the resolution of the monitors in the ED necessitated us changing this again. So, here's where we are, and this is work that is continuing to be iterated on. So this is just one example of potentially moving research into operations here at Children's Hospital of Philadelphia. And I'm now going to turn over the presentation to Dr. Winston, who's going to walk us through another case where the impact expands beyond the walls of CHOP.
Daria's amazing, isn't she? Incredible. So let me just say, there we go. So many of you know that I study child injury, and it really just pains me to know that to this day, it's still the leading cause of death for adolescents by far. 1 in 3 adolescents who die from car crashes. And what Allie Curry and our team did, using data that she linked together in multiple different ways, which we can talk about later, she was able to really look at what is happening here. And you go from your lowest lifetime risk of crashing to your highest lifetime risk when you become a new driver. There we go. Well, what we had is a breakthrough discovery in our lab where we were finding out that really most of these crashes early on weren't because they were hot rodding and doing all kinds of things. It was because they didn't know how to drive. They didn't have the experience. But unfortunately, the on-road licensing exam was by definition very simple.
And why is it simple? Because adolescents are high-risk drivers, and if they make it too hard, it could put the evaluators at risk. So all of a sudden, what we're doing is we're driving people around parking lots and trying to sort of guess whether or not they're going to drive well, and that's the state of the art with driving. And I thought, we can do better with that. And so we developed a simulated driving assessment, and it could differentiate drivers in terms of skill and experience, and it was predicting whether or not people could have it would have crashes, it was doing all these wonderful things. But here's the problem. It was in a big simulator. I don't know if you've seen it over at Roberts. It's enormous. There's no way that you can get this out into the field. So our very first de-risking question was, would people still find it immersive? Would they find it useful? Would they find it something that really would represent their driving if it weren't in this big, enormous simulator? And will it still be valid? Will we still be able to differentiate drivers in terms of skill and experience? Well, the next part about it is, okay, if we did that, who's going to use it, right? How are we going to deliver this? I still want to deliver it at CHOP, and if anybody in this room wants to use it in your clinic, please let me know. It's really easy to do, not with the big simulator. But there actually was a request for applications that came out from Ohio that they actually had legislation passed and were surprised. This is John Bourne, the director of safety for Ohio, that they actually had money to actually start doing it, which they were like, okay, I didn't expect to get money. I wanted the authority. But now what am I going to do? I don't have a simulated driving test. So we applied, and we were lucky enough to get it. But because this was very different from what CHOP does, and I can go through many, many stories about that, we actually did it through a company. We spun a company out of CHOP because then they could assume the liability, they could assume all the risk around this. But it still required a tremendous amount of translation to de-risk this, to iterate, get it right, make it immersive, make it valid, still get good results. And then we show up in Ohio, and they said, we really like it to be 5 minutes long. I'm like, 5 minutes? So we actually pushed them, though it's 13, actually mostly 11. But really, this was a huge shift from what we had in the lab into what we had to do in the field. But you know what? We've done it 15,000 times now. It's in the lab, it's in the field, it's being used by Ohio. We have a pilot test going, and we're able to predict who's going to pass or fail their on-road exam very accurately. So it really worked, but it took a very deliberate process to get us there, and lots of mistakes. So these are two examples, okay? They are hard work. You want to give up many, many, many times. And I know anybody here who's done an innovation project, there is a point where you're like, I just can't do this anymore. I want to stop. But what keeps you going? And what keeps you going are the people around you, the people who are pulling you and encouraging you and keeping you going and really being your cheerleaders and also your support. And that's what an innovation ecosystem is about. Being together for a larger mission than just what we're doing today. And that larger mission is children. We're all here. We have that one mission. So the path forward that we see is to take this valley of death, where we don't have enough resources in the middle, and actually move the technology a little further along. Push the technology a little further along with a lot of the accelerating we're doing within the hospital. Try to work with partners and try to figure out what they actually need so that we can pull the technology a little further along. But most importantly, build up our resources, build up who we are at CHOP, and that the fact is that we don't want to just study things. What we do is we want to create solutions. And that's where this innovation infrastructure comes in. And if we're really lucky, it's going to turn into a challenge basin rather than a valley of death. And that seems a little bit better way to go. So when I think about innovation, many of you, when you think about innovation, yell it out. What do you think of? What's the picture you see? Anybody here have a picture in their mind? If I say innovation, what do you think? Did I hear Steve Jobs? Okay, that is what we think of, right? As if he alone made all the iPhones, distributed all the iPhones, made them in his garage, right? He was in his garage, he was, had his soldering iron, and he was making all his chips. He was doing it completely by himself. And you know what? He never made any mistakes. It was all that is such a myth. It wasn't that. He was brilliant. He was a visionary. We're all sad he's gone. But the reality is there was all this stuff around him. Not the least of which are the end users who ended up being, avid fans of his products and really pulled that technology out as far as it could go because it was so innovative. Yes, he was innovative, but the innovation that actually derived value required a whole lot more than just Steve Jobs. And so when we have our vision, and you'll see this is draft, because right now we're in first planning year that Brian Wolf and Paula, I'm so glad to see Paula here, are so generously funding to really start thinking about innovation ecosystem work and how do we build CHOP and build the capability to move this stuff forward. And what the vision is that it won't be pockets of people who are sitting in Abramson or sitting in Roberts or maybe, like just even on a floor in one of these buildings, but really across the entire network and include our families and include our partners, that we're going to be 1 degree of separation between us with an idea and an innovation champion who really knows how to navigate the system and help you through that process from discovery to impact. There are skills, there are things you need to know. Just like if you were going to have neurosurgery or your a family member, God forbid, was going to have neurosurgery, you would go to a neurosurgeon, they have skills. This is the same thing with innovation. There are skills that take you over that valley of death. And so the aims that we're thinking about is to integrate CHOP's innovation activities into pipelines from idea to implementation. And it doesn't mean that we are going to do away with any of the innovation hubs. They're fabulous. And they are focused and they get things done. But what are those bridges between them? What are the things they all need? What is that support infrastructure, the spider web around it all that really makes it work? So it's an organization-wide culture, language, and competencies around innovation. When you look at our, for those of you who are CHOP employees, if you look at your job description, innovation isn't even in there. So let's think about that. If we're going to be the ones leading healthcare, we need to understand innovation. So when we think about it, we think that these 3 things, connection, capacity, and culture, bridge that valley of death. And we can do it. We can do it at CHOP and our partners and our infrastructure, the University of Pennsylvania right next door. So much, we've got it here in this room, I would imagine. So the first is building connections. And this has been a really fascinating thing to understand. You're going to hear a quote later or two from General McChrystal. So when you think about it, with highly organized places like CHOP, it's by definition hierarchical in its organizational structure, and there's a good reason for it, because we are doing very complex things that have high risk, people's lives are at stake, and it's got to work every time. Like when my child shows up in this hospital, that child better get the same care as the next kid, and there should be no safety problems, there should be no challenges there. So it needs to be consistent, it needs to be accountable, and it needs to be managed, okay? That's how you deliver great care, but that's not how innovation works. Innovation works much more informally. You need to be interconnected, bringing people together. That's how you generate creativity, because you happen to hear something new from somebody else instead of being in your echo chamber where you're always talking to doctors, or you're always talking to nurses, or you're always talking to informaticians. You need to be, this generates the innovation, the new way. You're frustrated, you want to get around the edges, you talk to people, creating new value. But the most important thing about what's happening in healthcare is we're getting more and more, not just complicated, but complex. And hierarchical structures are important for delivering care, but they do very poorly with complexity. And this informal network is the thing that's going to help us to really think about the complexity and the disruption that's going to come from Amazon and from everything else that's facing healthcare these days. The next is about building capacity. There are things that we all learned in school, right? We learned how to be good doctors, good nurses, good computer scientists, good all this stuff, and we got all those skills. And my goodness, the people at CHOP are phenomenal. The way that we deliver things is fabulous. But these are skills we didn't get, right? I mean, we just never got them, and we never learned things like design thinking or product market fit or any of these kinds of things. We just didn't learn it, right? We didn't learn how to do things with, I think Sandy there, with personas of our patients and thinking about designing from the perspective of the patient. We didn't learn it, right? And then you do it once and you're like, oh my goodness, no wonder why healthcare is broken, because we're designing things without these skills. So we need to build that capacity so that we more understand the skills and know how to work with people in design. And then there's a part about thinking about evolving the culture. The culture at SHOP is fabulous and supportive and wonderful, but because a large portion of what we do is about delivering consistent quality care, the temptation is to lead as a chess master, controlling each move of the organization. And according to General McChrystal, who completely changed how we do things in the military and got the Navy to work with the Army and all the rest to break down Al-Qaeda, he said that we should be thinking more as leaders as being gardeners, enabling rather than directing. And I thought that was a beautiful way to think about it. And here's the one I like the most. We are an institution that never fails. We do not tolerate failure. But by definition, innovation requires failure. So we need to think as leaders about how we can let people fail, but not call them failures. And that's the part that I think is going to be one of the most challenging, because we are so used to getting that P less than 0.05. And if you don't get it, then you're not promoted, or you're not this, or you're not that. And it's a different way of thinking if we really want to get to this innovation ecosystem. So here's some innovation equations just as a summary of what we talked about. The first, from our definition, lots of wonderful things are happening in improvement, in all these kinds of things that we're doing. But innovation is a new way. It was never done before. And we're doing it that way, and it's going to create value. That's what innovation is about, okay? It's more than the shiny new object. I know that that's such an easy way and a sexy way of showing it. Like you see that shiny new object and everybody's all excited. But honestly, I'm really happy that I don't have to go to the bank to deposit my checks, right? That is an innovation that changed my life. The shiny new objects, we were just talking about one that I was about to buy. I'll buy them because they're really kind of cool, but I may not even use it, and it may not make my life any better. So if we're really thinking about reducing suffering and improving the health of patients, it's about thinking, what is that innovation that they need that's going to solve the problem? You have to be in love with the problem, not your solution, okay? And then the next is that innovation, by necessity, includes failures. You are going to make mistakes. Things are going to break. They're not going to work. And that's how you learn, and that's how we grow. And we need to share that with each other. We need to applaud our failures and talk to each other about it and not be embarrassed. Okay? That's why we came out immediately telling us that we made mistakes. I made lots of mistakes in the way I did it. Doing something in a huge simulator was never going to scale, right? So that's important to think about, and it's also important for guiding that decision space. So when you have a fabulous idea, and I see Mark here and other people I've talked to, we always bash it up, right? We always are trying to find, how is our work going to fail? How is it going to fail? And what can we do to test, to design for failure, to limit that, but then how to test to see if it truly did fail, and then find the other things. And then the last is that innovation is not about individuals, it's about the individuals in a supportive ecosystem, which is what we're hoping we can create at SHOP. So with all that, now I'm turning it back over to you, right? Because remember, it's not individuals, it's not about me, and it's not about Daria, it's about all of us. And so I wanted to begin a discussion. This is the very first time that we are presenting this presentation publicly. So you are our guinea pigs. We want to know how we failed. We want to know how to make it better. But most importantly, we want to know what you can contribute. What are you thinking about here that makes sense for what you can contribute and what you need to do it? So I want you to just open it up. Any questions you might have, but also really starting the conversation. Please.
beginning and at the end of the talk, you talked about the frequency of failure, and through the body of it, you talked about the need to avoid failure. What I didn't see in the model is any suggestions about how to use failure systematically to innovate effectively and successfully.
Thank you so much for asking the question about using failure to understand things. And we actually had way too much to talk about in 45 minutes and would love to talk more. But really those are about the falsifiable hypotheses. If you go into a process thinking about, okay, I need to be measuring X, I need to be measuring Y, I think people may or may not be engaging in this. This may not work. People might not. You put that measurement in right up front, and you start to include that data over and over again so that you know that, it's failing. I stopped here. I have to stop. But you include enough information so that you can know what to do next. And so it's this process. It's a continuous quality improvement process that is related to the design phase, where I tried this and it did or didn't work. I did this and it wasn't that. I mean, I was just talking to Sandy about, his new lupus clinic. And so the idea was he put ideas in place. Are you finished designing it? No, because he put in place an idea that this is what I had hoped my outcome would be. It didn't get to that point. I have to keep going. So it's really about measurement. And that's really the key. And that's the great thing about electronic health records and everything. There's so much more measurement we can have these days that can help us understand it.
So part of that transformation process, I believe, is what you just touched on, is the measurement. And so in the future state, where we're no longer measuring that P less than 0.05, but we're measuring maybe learnings and iterations.
That's a great way to look at it.
How do you see that being operationalized throughout the organization?
It's a great question about thinking about sort of not just having everybody talk about their successes, but also their failures. I think it's about information sharing. It's something that's happening in the informal networks, but not really codified and collected so that we have institutional wisdom. But I think that as we make mistakes or as we find ways that work, we should be thinking about how to collect that and have people have access to it. So, people who work with me know this. The second I do this, I start coming up with, okay, all right, fine. Now we have a new checklist. Doom, 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 doom. Oh, no, we got another one, and we've got a new way, we've got a new algorithm. It's just like, have that not be just in my head, but shared among lots of people. And we're starting to do more of that, like with all the QI that's working, the great work that Ron is heading up. He's developing a wisdom about how do we approach these kind of problems. And we need to develop that same kind of wisdom and resources and knowledge around innovation. So it's about keeping track of it, Like, how did we overcome this problem?
I'm a statistician, so
Great.
I think between the two of us, we should be really careful how detailed we get. But I just wanted to quickly say that the culture in statistics is changing very rapidly, and one of the things that's happening is those 10,000 failures that you said Thomas Edison talked about. We are starting to publish those.
I'm so glad.
And that makes life easier and more interesting for all the rest of us who are working on problems like that. But my question was, and this is the last question.
That's okay.
Apologies to anyone who needs those. You talked about classifying people into those who would pass and those who would fail the driving test. And I wondered if you might be able to say a little bit more about how you developed that classification algorithm.
Oh, it's a long story. I can answer it. I'll do it very shortly. So the first part, there are two different ways to do it. One is that we developed standard driving metrics that you can measure from the simulator. So you know how your car knows that you're 3 car lengths ahead of somebody else, or you're not, or whatever. There are all these things that we know what safe driving means. It means allowing enough space in front of you. It means not being in the space of another car at the right time, and all these other things that we know are involved in safe driving, which is how they're creating autonomous cars. And so those are driving metrics that can be derived from the brake, the throttle, and the steering of a simulated car, right? And so we've turned those into metrics. That's one way we're doing it. The other is through machine learning. And one of the other whole end of the spectrum is that basically the drive in a simulator is just how much you depressed your brake, how much you depressed your throttle, and how you steered, right? So you just have those three variables over time, so time series, and we're starting to categorize people at how close are you to a perfect driver or a bad driver. And so we have both methods. We have actually Liz Walsh is right here, and we're doing all kinds of even more methods. I'd love, love, love to talk to you about my research. So let's get together and talk about it, because it's incredibly fun, and we are on the cusp of getting licensing and crash data from Ohio as well. And so we're not just looking at pass or fail in the on-road exam, but we're looking at other things as well. So actually, this is the important thing. Everybody who came in for an on-road exam in Ohio also got our simulator test. So for these now we're up to, I think, 5 or 6 sites, everyone got both. So like it was something that we had the denominator for both of them, which is just unbelievably fabulous. It's been so wonderful working with them.
What about the installed base as a barrier to innovation?
The what?
The installed base. I'm thinking of the QWERTY keyboard.
Oh,
Designed to screw us up.
right.
And it succeeded, and it would take like 2 weeks and we could type 20% faster, and none of us do it.
Yeah, so that's like about legacy systems. The technology you already bought, you got to repurpose it, you got to keep using it. And, eventually it breaks. And so then the opportunity is to think about something new. But I do think that that's a problem, the QWERTY keyboards and other issues where we know we have substandard technology, the whole Betamax versus VHS kind of thing, or whatever it might be. We have what we have in technology. And so here's the reality. When you've got your innovation and you're developing it in the lab, you can do whatever you want. You can have your any keyboard or whatever. But when you go out into the field, you got to use what people have, right? And so you've got to optimize for the conditions that are actually out there in the field. You can't, that's the part. You got to figure out what is the easiest lift, because no matter what you do with innovation, it's going to be hard. And a hard lift would be to tell everybody to have a new keyboard. So I agree with you. If that's the answer you're saying, is that until it comes to the point where people won't tolerate that keyboard anymore, there's so many of them out there that we have to design for the existing keyboard and come up with better solutions. It's a trade-off. And Christy and I know that from all the work we've done in cars. There's some, if we wrapped every child in a bubble and put a helmet on them, in bubble wrap and put a helmet on them, they probably would never get hurt. Well, no parent's going to do that. So we then have to back up. Okay, well, what's one thing okay, car seats. They're not so great, but we can do that. So I think that's just the reality of the world. People are going to do their easiest solution, and doing the thing you're already doing or doing nothing is the most likely alternative solution to something new. Christy.
Laura, I'm going to ask a question that you and I talk about a lot. Hearing you describe this process, to me, says we need different disciplines. Disciplines that aren't necessarily part of a typical hospital or hospital-based research institute work staff. How do we create an environment where those disciplines are attracted to come here and see opportunity and a career path and buy into our mission internally?
So that is one of the biggest challenging things. I think about CHOP, and I can't believe that on a campus, 60 different campuses with 16,000 people, we don't have a machine shop or a machinist. That's like an amazing thing to think about. But it's because we were designed to deliver care. And I think that CHOP is in a new place. I love these enlightened leaders like Paula and Madeline and Brian. They're enlightened leaders who realize that we need to think differently in order to solve the problems that only we can solve. And so thinking about that, it's about thinking about how do we handle this? I mean, how many of you are informaticians working in a hospital? That's new, right? They didn't used to have computer scientists working in hospitals, but they have them now. And so I think that the idea that we're going to be developing new technology and new medical technology and all that, you know, to start with, CHOP is using a lot of vendors. But as time goes on, you might say, well, you know what? Maybe we need that internal capability. Or within an ecosystem, you have your trusted partners. And so I think we need to create career paths for the innovators. We need, and not just the people who are inventing things, but the people who are enabling those who invent things. And we just haven't developed the career paths for them. And I think it's crucial for our future. Yes. Bye.
I just, my neighbor here actually queued up my comment and question perfectly. So I don't have to go right after. We did not plan this. I'm Susan Perkins-Regley. I'm actually a human factors scientist at Penn. I am the only one at Penn.
Can you imagine? It's like crazy.
And I mean, I was on a panel with a bunch of other people like me who are the only person doing, specifically doing the expert doing human factors, and my expertise is more particularly human-computer interaction. So I'm on a mission to preach to both sides, to hire into the hospital. And I say this to Mikey in the same talk at the Human Factors Institute at Carnegie Mellon, the human factors people, to try to get jobs in the hospitals. Because the building capacity, you can learn how to do design thinking, et cetera. And that's great and that's wonderful, but when you really want to do a project, you need an expert. I liken it to the difference between me diagnosing myself with a WebMD with a cold or needing an actual neuroscientist if I need it surgery. But that relates to my comment, which is, my question, which is, one of the things I've been thinking about a lot is how do we do this? It's sometimes easier to do the bridge over the valley into commercialization or into the field than it is to do into the hospital.
We just talked about that yesterday in an OEI meeting. Yes.
So I think you guys are doing phenomenal work, and I just would like to understand. That's me timing my question. I'd like to understand your thoughts on that, and maybe begin a dialogue on that.
I would love to talk to you about it. I did want to do, before I answer that, I want to have Daria come up. I realized that she wasn't answering any of these questions, and I want her to be able to also. So I think that what we're starting to do at CHOP, for example, with the chairs initiatives, which is we can tell you, the innovation programs and the funding, and it's amazing. And one of my favorites is the chairs initiative out of the Department of Peds, where clinicians and teams can find problems that they think they need to solve, and they can make a difference in 2 years. We've added, after the first year, a sustainability meeting. So the idea is that you're thinking about, I'm not going to be in this thing forever, right? Like, I'm not going to be testing people on the road in Ohio. That's just not my job. So I need to be thinking about who I'm going to be handing this off to. And the expression that I've heard is, if you want me to buy, I have to shop, okay? So the idea is that you need to think about who they are and create what they need in their product. That's the technology push. And then they have to tell you what they need in their product, the technology pull. Christy and I have been doing this forever with the auto industry, trying to give them what they need so that they can make better products, right? So as we're thinking about our innovation, we need to think about who's going to actually implement that and learn from them. So that's really, it's a skill, and it's actually really fun. You realize how much you don't know. But I completely agree about the embedded engineer. How many times have Christy and I got, why is an engineer at a children's hospital? Well, you guys who fix the pumps? No, actually, we do research, you know, and so we get that all the time. Yep. Okay, so we have one last slide. Do you want to, and we want to support each other, right? Notice that there are women on the bottom here. I just want to say in the picture. So you want to talk a little bit about this?
Sure. So I like lunch, and that's what I'm going to do after this. And I hope you like lunch too. And this has been a very engaging conversation. We have heard a lot from you, but we are really excited and would really like to continue the conversation. So we're going to have lunch. So we have this survey here. You can for the first 20 people to respond. It's super, super short. It's really easy. And if you fill out the survey and put your email address, then we're going to have you come to lunch in the next 3 weeks. And we'll continue to talk about this more. Bring your ideas. We can also continue to share with you the early learnings that our innovation ecosystem group has been doing. So we'd love to get your feedback on that and seeing what resonates with you. So you can either point your phone to this QR code or you can go to this link and fill out the red cap survey. There's 6 questions. Lunch. It's going to be great.
So it's https://is.gd/innovation to impact. With the number 2.
Number 2.
Any last questions, maybe for Daria, because I took over the microphone too much?
No, I just wanted to make one comment about the challenge within the hospital system. And I think, I'm seeing Bimal Desai, who's sitting here, who is one of our clinical informatics faculty and leads the leadership rotation. And I think, you mentioned that it seems like it's easier to translate to the commercial space sometimes, because I think there's also kind of precedent in like setting expectations, right? Like, they expect like there's going to be like some, like doing marketing is like part of the expected process. And, Bimal and I have talked about, well, that needs to happen internally too, not necessarily calling it marketing, but as you're innovating and thinking about these things, like what is the long-term plan? And so, you need to engage those stakeholders and find the strategic alignment and be able to do the pitch to your internal colleagues as well. And I think it's just not as established a precedent, but I think, with our leadership here at CHOP, we've really been starting to see that, and I think that's been attributable to some of our success as well, and will be an area that I think we will continue to improve upon. But I think that really is about setting expectations and kind of, it's just not an expectation that we have a preconceived notion of within the healthcare system yet.
Let's thank our speakers.